Okay, sorry about that. I had to step out for just a second. So we were talking about respiratory depression, and this is predominantly a result of the opioid actually blunting the sensitivity of the baroreceptors for carbon dioxide and pH changes. Now, why is this important? Asking a patient if they're short of breath will not give you any kind of indication of whether they're having opioid-induced respiratory depression. There are three different ways that we can assess that. We can assess respiratory rate, which is the least sensitive. We can assess oxygen saturation, which is the next most sensitive. And the absolute most sensitive way to monitor for respiratory depression, and this usually only happens in hospitals, is something called end-tidal capnography, or end-tidal CO2. Where do we have the biggest problem with respiratory depression? Like I said, when we put someone on, when we increase their dose, when they're on another drug like benzodiazepines, or if they have obstructive or sleep apnea. Now, I have down at the bottom significantly increased with benzodiazepines. And in fact, the recently released CDC guidelines for the prescribing of opioid therapy, and I'll pull those up probably in class and go over them, basically recommend completely against using benzodiazepines with opioids. So let's talk about renal insufficiency. I don't want you all to try to memorize this table. It's here for your reference for when you get out on rotations. However, what I do want you to pay attention to is that morphine can actually accumulate in renal insufficiency. And remember that there's a neurotoxic glucuronide metabolite of morphine, which is called morphine-3 glucuronide. And so most hospitals will actually try to avoid morphine use when you have a patient with a creatinine clearance of less than 30. I do want you to know morphine, and I do want you to know creatinine clearance less than 30. I think that's important. The other thing that I think is important to note is that we do not use meperidine in renally compromised patients. We really shouldn't be using it at all, but if it is being used, if your patient has any type of renal insufficiency, that needs to go away. As far as hepatic insufficiency is concerned, probably the biggest one that we will see is the use of fentanyl in hepatic insufficiency, and so we've really got to pay attention to the dose. We also have to pay close attention to tramadol as well as buprenorphine. Again, please don't necessarily feel like you got to memorize anything on this, but I would definitely remember that some of these drugs do need to be adjusted based on predicted hepatic function. This is basically for those of you who may be going into peds. This is just for your reference. Please don't feel like you need to memorize this by any means. And the other thing I would encourage you is that these doses change very, very frequently. And so please make sure that if you're going to be dosing an opioid for a child, an infant, a neonate, whoever it might be, please look up current information and double check. Do not use the information on this slide as the end-all be-all dosing recs for kiddos. Older folks or older adults are equally sensitive to opioids as young children are. They have a much higher sensitivity. The actual changes in blood pressure and heart rate can be more pronounced the older you become. And you also typically need less opioid to get the same effect as we get older. The thing that needs to be taken into consideration is when we're doing these equal analgesic conversions that I'll show you how to do later, you really need to figure out what the creatinine clearance for these folks are as well. So that, I think, is reasonable to come back to some of our opioids and what is the actual fate of these drugs. Now, the reason I have this slide on here is for two particular reasons. The first reason is obviously drug interactions. So, for example, if you have a patient who is maintained on fentanyl and you give them a potent 3A4 inhibitor like clarithromycin or Biaxin, that can result in potentially toxic or fatal levels of fentanyl. On the flip side, if you have somebody who is getting a 3A4 inducer like carbamazepine, for instance, they might have a very shortened duration of action of fentanyl and may have a blunted pharmacodynamic effect. The other thing that we need to keep in mind is that there are pharmacogenomic considerations too. So you have patients who might be cytochrome P450 2D6 poor metabolizers, and ultra-rapid metabolizers that can affect how quickly these drugs go to their active or inactive metabolites. Now, what I do want to make sure that you're aware of, and I know this was already said, is that codeine is a prodrug. Codeine must be metabolized to morphine for any analgesic benefit. And one thing I'm not sure I heard in any of your previous lectures is tramadol is the same way. Tramadol must be metabolized to its O-desmethyl metabolite, or M1, via 2D6. Oxycodone has analgesic activity of its own, but it is also metabolized to an active metabolite called oxymorphone. Brand name is Opana. And hydrocodone is the same way. It is metabolized via 2D6 to hydromorphone, brand name Dilaudid. So both of these drugs have analgesic activity, but there are active metabolites that need to be considered. So here's our equal analgesic opioid dosing table. Now, for those of you who are in the pain elective, I know that this is reviewed from Dr. Ferguson's lecture. For those of you who are not, I want to take just a minute to review this information so you get kind of a general idea of what we're talking about when we convert equal analgesic doses. So if you look at this, we basically can say that morphine and hydrocodone are equal analgesic to each other. So if you're on 30 milligrams of morphine and you want to switch somebody to hydrocodone, theoretically you could use 30 milligrams. However, there is some cross-tolerance issues where we can't necessarily use this table as the end-all be-all. So really what we will most often recommend is that if the patient's pain is relatively well controlled and we're just switching from one drug to the other because of tolerability issues or administration route issues, then we will reduce the target dose by anywhere from 25 to 50%. So really, when I told you that the hydrocodone dose here should be 30 because it's 1-to-1 with oral morphine, really what we're looking at is a target dose of probably more like 20 milligrams or maybe 22. I know you can't do that, but you catch my drift. It's not actually 30. And so if you use that rationale of how to do this, you can actually set up and figure out how to get between, say, intravenous hydromorphone and oral morphine. So you got a patient who's on hydromorphone PCA pump in the hospital, and now you want to discharge them on oral morphine or even oral hydrocodone or even oral hydromorphone. You have this conversion chart handy that will actually allow you to move in between these drugs. For the purposes of the test, I will provide this for any equal analgesic dosing questions I have. If you have a patient who is in severe pain, very frequently we will not reduce the dose for cross-tolerance. So if I had a patient that had 9 or 10 out of 10 pain and I wanted to go from morphine to hydrocodone, that would be a more realistic 30 to 30 conversion. And part of the thought behind that is that uncontrolled pain can actually have some protective effect against respiratory depression. There's no data to back that up, so please proceed with caution using that philosophy, but that is the philosophy. So the other thing that's a really big issue right now, and you see listed down at the bottom, is the new CDC guidelines for prescribing opioids. I don't know how I really want to approach this with you all. It is now the accepted guideline for prescribing these drugs. There's 12 key recommendations, most of which we'll cover anyway. But the ones I think that you really need to know about are that they don't recommend going above 50 milligrams of oral morphine equivalents a day. When I say oral morphine equivalents, remember we're talking about this. So they don't recommend going above 50 a day. Rarely should you need to go above 90 a day. And they state that for acute pain, opioids should not be used for longer than 3 days, and rarely are they needed longer than 7 days, and that the risks outweigh the benefits for the use in chronic pain. Now, there is a lot of pushback on these particular guidelines. The data that they use to come out with these is very questionable and of low quality. Unfortunately, it is our reality right now. So until something changes, I would suggest that maybe you take a look at the one-pager, the 12 key recommendations that basically say don't use it with a benzodiazepine, the dosing recommendations, And they will also recommend that patients that I believe are on more than 50 oral morphine equivalents a day should be provided with naloxone rescue therapy. So where does a lot of this come from? Where are these dose limits popping up from? Well, we have different guidelines who basically will state what they consider to be high-dose opioid therapy. And obviously that's a lot higher than what these CDC recommendations are touting down here. Where a lot of this comes from is data from 2 or 3 years ago, whereas we start to get up above the 100, 120 milligram dose of oral morphine equivalent, we started to see an increase in the risk of overdose-related deaths. Well, obviously that's a bad thing. Where is that coming from, though? Is it coming from patients that are unintentionally overdosing due to illicit use? Is it patients that are using it for chronic pain and have been stable on it and then just all of a sudden die? We don't know. We don't have that data. And so I think that this is kind of a trigger, a hair trigger response to what's going on, but we needed to do something. The other thing that's very important is I talked to you a little bit earlier about sleep apnea concerns with opioids, and this is a big one. What we're most worried about is central sleep apnea. Remember, obstructive, you want to breathe, you have the drive, you just can't move the air. In central sleep apnea, there's no drive, and so obviously that's more important and more potentially harmful. And you'll notice that as the morphine equivalent dose goes up from this one particular study from Walker and colleagues, that your rate of central sleep apneic episodes start to increase, and they continue to go up and up and up. And that can be very dangerous. So let's talk real quickly about moving through some of the different unique drugs. So this is for the fentanyl patch. And the transdermal patch is, I think, a very dangerous method of delivering opioids because so many things can affect it. You'll notice the dose conversion guidelines that are here in the top chart, and this is directly out of the prescribing information. And these are considered to be very conservative. So they've already taken in that 25 to 30% or even 50% dose reduction due to lack of cross tolerance, and then converted over and given you recommendations on where you should start based on the total morphine dose. You do need to know that there is a 12.5 or 12 microgram per hour patch that is available for patients who are on lower oral morphine equivalent doses. Most of us in the pain community will actually use the Breitbart method, which is the 2-to-1 trick. And basically we'll say whatever the oral morphine equivalent dose is per day, multiply that by 2, and that's their fentanyl dose. Or excuse me, divide that by 2. I guess we got to make sure that we have that straight, right? So it's 2-to-1 morphine to fentanyl. So excuse me, if you're on 60 milligrams of morphine a day, let me repeat, 60 milligrams of oral morphine a day, then your target patch, if they made it, would be 30 micrograms per hour. If you were on 100 milligrams per day, your dose would be 50 mics per hour of the patch. That's using the Breitbart method. So all of these have different methods of converting between oral morphine and the patch. Here's 3 of the most common. You don't need to memorize these, but the Breitbart method or the 2-to-1 might be handy to put in your back pocket. The thing you do need to be careful about is if you try to go back from like a 25 mic per hour patch to say one of these doses, remember you were very conservative coming this way, so you're going to wind up being overly aggressive coming this way, and you need to be careful because you might overdose the patient. There are a number of transmucosal fentanyl products that are available. You have Actique, which is the lollipop, Fentora, Onsolus, Abstral. Those are all either buccal tablets or films. You have Subsys, which is a fentanyl sublingual spray. And then you have Lazanda, which is a fentanyl intranasal spray. All of these are fast-acting fentanyl products. These all are covered under the transmucosal fentanyl REMS program and have limited distribution. There's, again, probably not necessary to go through all of these different things. I just basically put this up for your reference. Please don't spend any time other than just for your own interest looking at these, but this may be handy one day down the road for you. Sublingual fentanyl or Subsys has its own method of delivery and priming instructions and all of those things. And this is what the Turf REMS website looks like. You can register for this as a pharmacist and become registered for Turf in order to actually stock the medications within your pharmacy. The thing that I absolutely, positively need to make sure that everyone in here is aware of is that you always start at the lowest dose of fast-acting transmucosal fentanyl. Because remember, what you learned from Dr. Nieto is that fentanyl is incredibly lipophilic. And so it can cross the transmucosal membrane into the vasculature very, very easily. However, you can also swallow some of it too. And so there's a lot of inter-patient variability, and we can't say with any kind of predictability that this amount of microgram of fentanyl patch should be converted to this amount of transmucosal fentanyl. Always start at the lowest dose and titrate up from there. The other thing, too, I need to make sure that you all are aware of is that some of these things look pretty fun to kids, especially the Actique lozenge, which is on a stick. It looks just like a Dum Dum lollipop, and it's actually made out of the same ingredients that they use to make the little candy stick from those Lick-A-Maid candy things or whatever they're called. So it's very sweet, tastes very good, and it will also kill a child that gets a hold of these things. So make sure these things are disposed of properly. So let's talk about some of the more unique opioids, because I know that you all talked about a lot of these already in your previous lectures. Buprenorphine is probably one of the more underutilized medications in the pain management world. Unfortunately, there's a lot of baggage that goes with it from a prescribing standpoint, particularly if you want to give buprenorphine either alone as a sublingual tablet, or if you want to give it in combination with naloxone, which is Suboxone. Now, buprenorphine works as a partial mu opioid agonist, so it actually kind of has antagonistic properties at the mu opioid receptor. That means that there's probably very low respiratory depression liability with this drug. It's a kappa agonist, or a kappa antagonist, and it also affects nociceptin receptors, which is that new ORL opioid receptor. Has a very high binding affinity, so if you're on another opioid, it will knock it off. The important piece of this is if you have somebody on Suboxone or buprenorphine, what winds up happening is that it can take quite a while to actually have this drug let go of the opioid receptor. And so what you can wind up seeing is that they get little to no activity from other opioids for quite some time after discontinuing it. There is a transdermal patch called Butrans that is available, like I said, as a 7-day patch. It's a matrix patch, so the drug is embedded within the adhesive of the patch. And it's available in 5, 10, and actually now 15, as of just recently, in 20 microgram per hour patches. FDA does not recognize doses above 20 mics per hour because of QT prolongation. And you also have to be very conscientious about how you convert somebody from, say, oral morphine or oral oxycodone to the buprenorphine patch, because you actually have to reduce the opioid dose before you stop it and put them on the patch, because you could put them into withdrawal. So it can be a very big issue. This is the recommendations from the prescribing literature on how to actually do that, and you'll notice that if you are on doses greater than 30 milligrams of oral morphine, but less than 80, the prescribing information actually recommends that you reduce the dose to 30 and then initiate a 10 microgram per hour patch. Folks, that is really tough to talk a patient into, especially when they already have poorly controlled pain. Methadone is a very interesting, very unique, very effective, and also very dangerous opioid. It does have an active parent. Its metabolism goes through 3A4, 2B as in boy 6, and 2C19. All three of those have significant drug interactions, as well as some very worthwhile to discuss pharmacogenomic concerns as well. Its half-life can range, good gosh, anywhere from 7 to 60 hours, and it can cause QT prolongation, predominantly due to the racemic mixture, or the S isomer of methadone. There are specific monitoring recommendations that come with this drug from some new methadone monitoring guidelines. They basically want you to get EKGs at baseline. They want you to get more EKGs at more than 30 and again at greater than 100. And they want you to stop the drug if you get up to a corrected QT interval above 500 milliseconds. So we do monitor methadone patients very closely. And remember I told you that, sorry about that. I did tell you that there was a lot of the opioids that can cause NMDA agonism or stimulation, which is bad for pain patients. Methadone is an NMDA antagonist. And so that's potentially why there is some anecdotal or clinical observational data that methadone may actually not have the dose escalation, the tolerance, and maybe even the opioid hyperalgesia that's seen with some of the other drugs. So how do we dose methadone? Well, there's a number of different ways that we can do this, but most importantly is that the potency of methadone changes based on the current daily oral morphine equivalent. So it can go anywhere from 3-to-1 in potency all the way up to 20-to-1, depending on how much morphine the patient's on. Again, if we want to do methadone on a test, I will give you this, but please know that you can't use a chart, and it's also very difficult to use some of these online calculators unless you look to make sure that the potency calculation changes based on the oral morphine equivalent dose. The other thing you need to know is you're not going to see the actual effect of a dose of methadone. So if I start you on methadone today, I'm not going to see the full effect of that dose of drug and what I'm going to get from it for pain relief until this time next week. So if a patient calls me back and says, hey, it's not working 2 days later, don't titrate the methadone, because we still don't know what the actual max effect of that dose is going to be. And you can put them into either over-sedation or respiratory depression. So do not adjust the dose more frequently than once a week. When we're converting, so let's say that I have a patient, just for giggles, let's say I have a patient that's on 600 milligrams a day of oral morphine equivalents. Well, what that equals to, based on this method, is that I would use a 10-to-1 conversion. So if we divide 600 milligrams of morphine by 10, that should give us your target methadone dose. Well, if we use this, that would give us 60 milligrams of oral methadone a day. Well, unfortunately, that's too much. And so what we really have to do is we've got to reduce the dose, regardless of whether the patient is in uncontrolled pain or we're just moving the methadone for other reasons. You still need to reduce the dose by a minimum of 50 to 75%. And in fact, there are new guidelines that recommend reducing it as much as 90%. There are some different methods for converting. Most just use the stop and go. So I stop the morphine, I start the methadone at my target dose, and then I give them ample immediate release opioid like morphine or oxycodone to tide them over as a PRN drug. In the opioid naive patient, this is a scary one. You can do this, but you need to go really, really low. We recommend 2.5 every 12 hours as a starting dose. And we'll do this a lot in the hospice patient. Another drug that's very similar to methadone, but without the QT prolongation baggage, is levorphanol. It's hard to get right now because the generic company was just bought out. It also is an opioid that's very potent, as you can see based on a similar chart down here. And it also, just like methadone, possesses NMDA antagonism, and that's a good thing. Its half-life is long, but not as long as methadone, so it's kind of a quasi-long-acting drug. But it does need to be dosed more frequently. And as you can see down here, based on the oral morphine equivalent, we have conversion data that we can use. These are the commercially available oral opioids currently. I do want to point out that Avenza was just taken off the market. And we do also have an extended release tapentadol now, or Nucynta ER, that is not listed within this slide deck. So I apologize for that. Propoxyphene has been taken off the market, and we no longer have combination products more than 325 milligrams of Tylenol for either hydrocodone or oxycodone. So just some quick things to make changes to on the hard slide deck that you have in front of you. So what do we do with this? So right now we're playing this, this tug of war between the pain management specialist and the addictionologist. And the big issue is do we adequately treat pain and expose patients to potentially addictive medications, or do we let patients suffer because we're worried about the population as a whole having access to these medications? And it is really becoming a problem. One way that we will address this, and this is also outlined in the new CDC guidelines, is risk mitigation strategies. And really what risk mitigation strategies are is they're methods to try to maintain access to these drugs while minimizing the risk of abuse, misuse, diversion, addiction, etc. From a global perspective, we have a number of different methods for battling these risks. We have REMS programs, which stand for Risk Evaluation and Mitigation Strategies. We have the older PROP, or Physicians for Responsible Opioid Prescribing petition, and that basically requested that we have labeling changes to the controlled release and immediate release opioids, limiting their use to severe pain only. And we also have the Prescription Drug Monitoring Program. We should be very proud to be next to the only state in the union that does not have a PDMP. Our PDMP here in Illinois is actually pretty useful, and if you have any interest in actually getting on and seeing a demonstration of that, that is available on the website. There are some clinical things we can do to try to mitigate the risk associated with opioids. One of the things that we need to do is appropriately screen patients. So patients who are at really high risk for opioid misuse probably shouldn't be exposed to these drugs except under the most dire consequences. Things that can increase your risk of misuse include psychiatric comorbidity, a risk or a previous history, of polysubstance abuse, whether it's alcohol or opioid or non-opioid illicit drugs. For females, a history of adolescent or childhood sexual abuse has been identified as a very large marker as far as odds ratio for increasing risk of opioid misuse. And family history of polysubstance abuse can really increase the risk as well. And there's a bunch of appropriate screening tools that are out there and available. We use one called the SOAP, which is Screener of Opioid Assessment, Rater something, I can't remember what it stands for. And then we also use the COM, which stands for Current Opioid Misuse Measure. So those are some reasonable, clinician-administered tools that can be used. The other thing that we'll use is something called opioid treatment agreements. You'll hear these called contracts sometimes, but they're not going to stand up in a court of law. They're not contracts. They're basically informed consent documents. Here's what we're giving you. We are using a trial methodology for these medications. We expect you to get your drugs from one provider, from one pharmacy. We expect you not to do crack cocaine or heroin or any other kinds of illicit drugs. You also agree to allow us to do drug screening, either urine or saliva. You allow us to access your PDMP, although we don't have to have your permission. And you also allow us to do pill counts, look at your refill records, and talk to your pharmacist directly about your care. And that's one that I put in there and really like, because the community pharmacists, particularly that work in our area, are incredibly helpful for helping make sure that our patients use these medications safely. This is a algorithm that I developed for our particular clinic. And what it basically does is I think it kind of outlines the differences in the different urine drug screens. So remember, we have two predominantly different drug screens available to us within the urine category, and that's the most commonly one used in practice. We have the immunoassay, which basically uses the same technologies like a pregnancy test. You know, you dip it in the urine, it looks for certain substances that look or don't look like benzodiazepines, opiates, marijuana, cocaine, etc. And then we'll actually give you either like a little plus or a little minus or 2 lines or 1 line, etc. Now the thing is excuse me. The thing is, you can have certainly false positives with this, and you can have false negatives. What I recommend is that we always send any kind of questionable drug screen off for gas chromatography mass spectrometry confirmation, and we look for metabolites. And this is just a different way for us to assess what we find as far as the metabolites and what to do with them. And I put this together for our providers. So let's stop here and we'll jump into acute pain with the second lecture. I think we've about wrapped up our time. I really appreciate you all hanging in there with me. I know this is super long, super difficult to get through when you are sitting here listening to a talking head, and I'm sorry that I had to do that to you. But that is the end of the lecture. I guess we can wrap things up, and if you have any questions, please email me, and we'll go from there. Thanks again. Have a great evening or day or whenever you're watching this, and we'll talk to you soon.